We are live now.
Okay, thank you.
So, good evening and welcome to all. This is Ankana, the assigned moderator from IJCP Group. I wholeheartedly welcome all the delegates across the country in today's session. We are fortunate enough to get supported by the doctors. Thank you, all the doctors, for taking out time to join us today in the session. Okay, so the session is on hypercalcemia workup beyond primary hyperthyroidism. Hence, without any further delay, I'm taking this opportunity to welcome today's speaker, Dr. none other than our very well-known keynote speaker, Dr. Narendra Kotwal, sir. Sir is the Director of Endocrinology Department at Paras Health, Panchkula. Now, I would like to hand over the session to Dr. Kotwal, sir. Kindly proceed with the discussion. Over to you, sir.
Thank you, Chatterjee, ma'am. And I will take this opportunity to thank IJC Group for giving me this opportunity. And I would also like to thank all the delegates who are present in this session. I am sure it will be symbiotic activity. I will have a chance to learn from all of you. So what I'm going to discuss is as has been told, hypercalcemia beyond primary hyperparathyroidism. But I think it's also pertinent to discuss a little bit about primary hyperthyroidism. Also, we will discuss the whole of hypercalcemia. Now, and my this talk would concentrate on initially something about introduction, case-based scenarios, management, and way forward. Now, little bit about the calcium homeostasis. We know in parathyroid glands there are calcium sensing receptors. So what these receptors do, they sense the calcium outside. Depending on that, if there is a low calcium, PTH is secreted. Now, what does parathyroid hormone do? It increases the osteoblastic activity and osteoclastic activity on the bone so that more calcium comes out from the bone, increases reabsorption of calcium from DCT and collecting tubule. So there's a calcium absorption is there. And importantly, what it does that it stimulates 1-alpha hydroxylase. As a result of the active vitamin D is formed. What it does, it causes calcium absorption from the GIT. But at the same time, when 125 dihydroxyvitamin D is increases FGF23. And FGF23 inhibits the PTH secretion. From skin also, we know that vitamin D is formed, and this vitamin D, after 25 hydroxylation occurs in the liver. And then it comes to the kidney, where it's converted to vitamin D, and then vitamin D related things are concerned. So in the calcium homeostasis, we see parathyroid gland, kidneys, gut, and liver. These are the major players. Calcium, as all of you know, that 99% of the calcium is in the bone and 1% calcium is extraosseous. This extraosseous calcium is responsible for neuromuscular activity, vascular activity, and so many intracellular calcium is required for the hormonal secretions. So how do we define hypercalcemia? It can be defined as a serum calcium greater than 2 standard deviation above normal mean or lab limit in a reference lab. Generally, total calcium about 10.5 milligram per deciliter. But if we are doing ionized calcium, more than 1.4 millimole per liter. Now, hypercalcemia can be defined as mild, moderate, and severe. How do we define mild hypercalcemia? 10 to 12 milligram per deciliter total calcium, moderate 12 to 14, and severe more than 14. As far as symptoms are concerned, it can be non-specific symptoms like abdominal pain, there may be excessive thirst, fatigue, muscle aches. Just to recap, for hypercalcemia to occur, as I told you, three major organs are involved. Either there's accelerated bone resorption, excessive GI absorption, or decreased renal excretion. So, whatever may be the cause of hypercalcemia, generally this pathogenesis will revolve around these three organs. Like in hypervitaminosis, there is excessive GI absorption and accelerated bone resorption. In primary hyperthyroidism, there is a all these things are involved. Am I audible?
Yes, sir, you are audible.
think something happened. Okay, let me see what happened. Okay, as I told you, all causes of hypercalcemia revolve around three things. If it is hypervitamin D, there is accelerated bone absorption, excessive GI absorption. If there is a primary hyperthyroidism, all three things are involved. There is accelerated bone absorption, excessive GI absorption through vitamin D, and decreased renal excretion. Oh, if calcium is more than 14, there is a hypercalcemic crisis, which may be life-threatening emergency. But here I'd like to highlight that absolute calcium may not be important. It is the degree of hypercalcemia, how rapidly calcium is increasing, which is very important. And it may lead to decompensated state. It's though an uncommon complication of hypercalcemia. Here, I would like to emphasize one more point that hypercalcemic crisis we see more in non-PTH related causes rather than the PTH related causes. Why? Why so? Now, in hyperparathyroidism, if it is parathyroid adenoma related hypercalcemia, it is still PTH is still able to, its PTH is still suppressible by high calcium, though set point is at a higher level. Whereas in hypercalcemia, which is non-PTH related, it is autonomous calcium secretion from the either from the bones or from the kidneys. More absorption is occurring. So just to highlight one case, 33-year-old lady who presented with fatigue, constipation, and abdominal pain, calcium is 13.9, and a past history of renal calculus 3 years back. So what should be done next? Whenever we find high calcium, it should always be reconfirmed that this is hypercalcemia. So what are the causes of pseudo hypercalcemia? It can happen even if we have applied very tight tourniquet, because that causes local acidosis and increased protein can cause hypercalcemia, or conditions like paraproteinemia can cause hypercalcemia. So reconfirm hypercalcemia, and if there are paraproteinemia, please do ionized calcium. Then look at the corrected calcium. Then look at the PTH estimation that will determine whether it's PTH related or non-PTH related, and assess the severity. As I told you, mild, moderate, and severe earlier also 10 to 12 or 12 to 14 and more than 14. Mild hypercalcemia generally symptoms are anxiety, depression, anorexia, nausea, constipation, polyuria, shortened QT interval, and hypercalcemia, as you know, that it causes nephrogenic DI, which can cause increased urinary output, which is called hypovolemia, which will further cause calcium reabsorption from the kidneys. So it will worsen the hypercalcemia. In moderate hypercalcemia, we have cognitive dysfunction, anorexia, nausea, constipation, dehydration, shortened QT intervals, weakness. And in severe hypercalcemia, we have lethargy, confusion, stupor, coma, even pancreatitis, renal insufficiency, arrhythmias, VTs, and weakness. Now, as I told you, we have to confirm hypercalcemia, correction with albuminia, and correction of calcium for albumin is measured calcium plus 0.8, 4 minus, multiplied by 4 minus serum albumin. Review history and diet medication and lab investigations. Generally, if there's a hypercalcemia, homeostatic mechanisms that there should be increased urinary calcium. If you find low urinary calcium, it generally happens in like conditions, Miller-Kilkey syndrome, patient on thiazide diuretics, and family hypercalciuric hypercalcemia. Once PTH-related hypercalcemia is confirmed, we have to do radio imaging. Like in this patient, calcium was 13.9, ionized calcium was high, serum intact PTH was quite high, 442. So high PTH, high calcium is PTH-related hypercalcemia. So next is the localization. Localization done by the technetium 99 labeled system EB or ultrasonography, 4D CT. Other things, cholines, PET CT, trihexane PET CT may not be available everywhere. So, and radiological features of primary hyperparathyroidism, all of you know that there is subparacetal resorption, generalized low bone mass, extensive lytic lesion. Just if there are any PG students attending it for their, sometimes this is a biopsy question also, how lytic lesions of hyperpara are different from multiple myeloma in skull. Now, in multiple myeloma, you will find only punched out lesions, whereas in hyperpara, these punched out lesions are surrounded by sclerotic lesions because hyperpara increasing both osteoblastic and osteoplastic activity. So causes of hypercalcemia, PTH related are generally primary hyperpara, which can be there can be inherited cause variants like multiple endocrine neoplasia or family isolated hyperpara, or as I told you, family hypercalcemia or tertiary hyperpara. Non-PTH related causes, This is just a mnemonic. Vitamin traps. I will discuss other causes also. So vitamin traps is vitamin V is vitamin D A excess or D or A excess, immobilization, thyrotoxicosis, Addison disease, Milk-Alkali syndrome, inflammatory disorders, neoplastic diseases, thiazide rhabdomyolysis, AIDS, Paget disease or subarachnoid parental nutrition, and sarcoidosis. So as far as treatment is concerned, what is our aim? Aim is to inhibit bone resorption, increase urinary excretion, decrease intestinal absorption, and of course to treat underlying cause. If there is a mild hypercalcemia, please avoid factors which aggravate hypercalcemia. Avoid thiazides, lithium, dehydration, prolonged bed rest, and disease-specific approach. In moderate hypercalcemia, if it is asymptomatic, we can wait, and severe hypercalcemia would warrant immediate treatment. So, what are the treatment options? Most important treatment is the adequate saline hydration. We can start with isotonic saline. To start with 500 to 1000 ml bolus can be given over 1 to 2 hours, followed by isotonic saline around 200 to 300 ml, but ensure there is no volume overload, especially in the patients who have underlying cardiac dysfunction. Then another drug which can be used is the calcitonin. But mind it is not nasal calcitonin, it is a parenteral calcitonin, which is given in the doses of 4 to units per kg and 6 to 8 hourly. But problem with calcitonin is the tachyphylaxis. After 48 hours, there will be tachyphylaxis. But in terms of short-term measures, it can be used. The bisphonates are important to be given because they inhibit bone resorption, and zoledronic acid like 4 milligram over 15 minutes in 100 ml of normal saline can be given, and if required to be repeated after 7 days. But if there is a renal dysfunction, GFR is less than 30, we should not use it. Important to use after adequate saline hydration. I repeat, after adequate saline hydration, one can or may use loop diuretics, because loop diuretics causes the sodium loss along with the calcium excretion will also occur. But important thing is to ensure that there is no volume depletion with the loop diuretics. In fact, in many of the centers these days, loop diuretics are not used, and in fact, isotonic saline is enough to take care of hypercalcemia. Then one can use glucocorticoids, especially to decrease 125 dihydroxyvitamin D production from granulomatous diseases. Hydrocortisone, dexamethasone, prednisolone, anything can be used. Denosumab can be used to inhibit bone resorption, like 60 milligram of denosumab can be used. As far as the calcium mimetics, this is just for the completion sake I have written, not in severe hypercalcemia, but in mild hypercalcemia, PTH related or even secondary hyperparathyroidism, calcium mimetics can be used. And of course, if patient is not responding, then dialysis along with the calcium dialysate fluids can be given. So most important is the isotonic saline infusion, and then either bisphonates or depending upon denosumab or glucocorticoids can be used. In the first case, since it was a PTH related hyperparathyroidism, this localization was done. Patient was subjected to selective parathyroidectomy. As I mentioned about the cinacalcet, it is a calcium sensing receptor antagonist. Now, calcium sensing receptor recognizes cinacalcet as a calcium, so it leads to decreased PTH secretion. It is mainly used in chronic kidney disease and primary hyperparathyroidism if surgical option is not there. Dose is 30 to 90 milligram, and 4 weekly calcium monitoring is required. Coming to another patient, 60-year-old lady, she had a diabetes, hypertension for 10 years, well controlled on OHS, stable baseline serum creatinine is 1.1, prescribed with loss of appetite, weakness, polyuria, and vomiting. Calcium is a higher side, 14.6. There's a renal dysfunction, serum creatinine is 2.2, phosphorus is 4.7. Serum PTH intake is low, 9. Vitamin serum 25 hydroxyvitamin D is 45, and alkaline phosphatase is 135. ACE levels are high, and 125 dihydroxyvitamin Ds are raised. CECT revealed mediastinal and tracheobronchial lymph nodes, and bronchoscopy was done, which revealed non-caseative granuloma suggestive of sarcoidosis. In fact, 10 to 20% of the sarcoidosis patient may present with hypercalcemia. Now, coming to the causes of non-PTH mediated hypercalcemia, most common cause is the hypercalcemia malignancy, which is PTH or P related, which increases calcitriol because of the activation of 1-alpha hydroxylase, osteolytic bone mets and local cytokines, and prolonged immobilization. Now, vitamin D intoxication, As such, if we give a lot of vitamin D, especially, we see that sometimes patients are given injectable 6 lakh units, maybe twice a week or thrice a week, and these patients develop vitamin D intoxication. Or as such, if local vitamin D dose is more than 10,000 units is being given, it can lead to vitamin D intoxication. Chronic granulomatous disorders like sarcoidosis and tuberculosis. Why? Because there's an increased calcitriol formation because of the activation of 1-alpha hydroxylase. So overall mechanism of hypercalcemia in non-PTH related is a PTHRP related, which causes calcium release from the bones, and 80% of the causes are due to PTHRP related, and generally because of the breast malignancy, lung malignancy, and NHL. Sometimes PTH is also secreted from the malignant lesions, but it's very rare, less than 1% of the cases. Then increase 125 dihydroxyvitamin D formation, as I told you, which will cause increased intestinal calcium absorption, and less than 1% of the lymphomas can have this type of hypercalcemia. Then osteolysis, which causes the calcium release from the bones, generally breast, lung, and myeloma. The second, number two case was received hydration, furosemide, calcitrotin, denosumab till diagnosis was reached, and later on started on glucocorticoids after confirmation of sarcoidosis. And normalization of calcium, AKI, was resolved. Now, how do we approach PTH independent hypercalcemia? If no clinical, as I told you, most common cause is PTH-RP related hypercalcemia, and other causes can be vitamin D or it can be other causes. So one can do PTH-RP, 125 dihydroxyvitamin D, and 25 hydroxyvitamin D. If PTH-RP is elevated, it is humoral hypercalcemia of malignancy is more likely. If it is normal, then look at the vitamin D levels. If these are elevated, then there is an increased 1-alpha hydroxylase activity, which can be due to underlying lymphoma or granulomatous disorders like sarcoidosis, tuberculosis, even histoplasmosis, vaginal granulomatosis. If 125 vitamin D levels are normal, then look at the 25 hydroxy vitamin D. If elevated, this is vitamin D intoxication. If not, then look for the other causes. Please do serum protein electrophoresis or urine protein electrophoresis or serum free light chain assays. If abnormal, it's multiple myeloma. If it's normal, we have to look for the other causes. It can be like vitamin intoxication or hyperthyroidism, and various drugs can cause hypercalcemia. Thiazide diuretics. And here I would like to point out, generally thiazide diuretics causes hypercalcemia in a patient who has an underlying hyperpara, generally. But as such, if thiazide diuretics can also cause hypercalcemia in small minority of the patients, because it is causing volume depletion, which will cause proximal calcium absorption. The patients who are on the lithium. Now, lithium has got two effects. One, it is acting at the calcium sensing receptors. It is acting at the kidney level, causing DI, and DI can cause volume depletion and further calcium absorption. Anti-estrogens, excessive vitamin A, theophylline toxicity, foscarnet, immune checkpoint inhibitors, and aluminum intoxication. So this was one of our colleagues from Vedanta who had published this case, vitamin D toxicity, resulting from overzealous of correction of vitamin D deficiency. Now, teriparatide hypercalcemia, teriparatide is being given for osteoporosis and sometimes for bone healing by the orthopedicians also. It can occur in 5% of the patients, it can cause hypercalcemia. Serum calcium, once we give teriparatide, serum calcium reaches maximum at about 4 to 6 hours. It returns to baseline by 16 to 24 hours. So if we have to do calcium estimation, it should be done after 16 hours. If hypercalcemia is documented, we have to stop giving additional calcium and injection can be made alternate days. Very importantly, these days SGLT2 inhibitors are being prescribed by all, by physicians, by cardiologists, by nephrologists for renal protection, cardioprotection, and glycemic control. It is important to remember that it may cause hypercalcemia. So, what are the risk factors of hypercalcemia with SGLT2 inhibitors? Patients who have dehydration, as I told you, dehydration means intravascular volume depletion, which will cause a calcium absorption from PCT. Acidosis, which will cause calcium resorption from the bones. Calcium intake, patients on thiazides, presence of asymptomatic hyperpara. As such, once we give SGLT2 inhibitors, it has got little bit of SGLT2 inhibition also, which increases glucose delivery to distal gut. Then there is a bacterial glucose fermentation, decrease intraluminal pH, which increases calcium solubility and increase calcium absorption. So the patients who have dehydration, acidosis, increased calcium intake, thiazides, they may develop hypercalcemia. So one should watch for the calcium levels while on SGLT2 inhibitors. This is a very interesting case, hypercalcemic crisis associated with hyperthyroidism. So sometimes patients of hyperthyroidism, because thyroid hormone causes the increased calcium, bone resorption, which can lead to hypercalcemia. Other causes of hypercalcemia, miscellaneous causes, I would say, to rule out. Sometimes we don't find other causes, acromegaly, because GH causes calcium absorption. Pheochromocytoma, because it decreased intravascular depletion will cause the calcium absorption. Adrenal insufficiency, again intravascular depletion. Immobilization, there's an increased bone resorption. Parental nutrition and Bill-Culky syndrome. Yes, few words about the Bill-Culky syndrome. Earlier, in the past, about 30, 40 years, when a lot of milk used to be given and calcium used to be given, Bill-Culky syndrome used to occur. But now also, we see patients of Bill-Culky syndrome, especially when calcium carbonate is given higher doses. Now, it causes calcium absorption, the bicarbonate absorption is there, which causes alkalosis, which further causes the calcium absorption, and it can worsen the renal function. So patient can have renal dysfunction, hypercalcemia, and alkalosis. Just to tell about what happens to the calcium levels and PTH levels. In kidney failures, we see that this PTH level starts increasing, and in secondary hyperpara levels are generally 2 to 4 times the upper limit of normal. And later on, if there's autonomous secretion, tertiary hyperpara, PTH levels are very high. In vitamin D deficiency also, there is secondary hyperparathyroidism. And in primary hyperparathyroidism, there is a increase in PTH, which may not be very high, but generally calcium is also high and PTH is also high. And in patients of malignancy, PTH will be inhibited. So just to again revise the hypercalcemia approach, hypercalcemia, we measure immunoreactive PTH. If it is high, then one can look for the urine calcium creatinine ratio to rule out hypercalcemia due to hypocalciuria. That is familiar hypercalciuric hypercalcium, which is very rare, but of course it is there. If it is calcium creatinine ratio is low, it can be FHHH. But mind you, there's a lot of overlap between FHHH and primary hyperparathyroidism. And if ratio is high, then it is the hyperparathyroidism. If calcium levels are PTH levels are low, look at the PTHRP. PTHRP high, malignancy related, elevated 125 dihydroxyvitamin D. That means it is increased 1-alpha hydroxylase activity. Causes can be lymphoid, sarcoid, or granulomatous disorders. If elevated vitamin D toxicity. If normal vitamin D, normal PTHRP, other causes to be ruled out like myeloma, vitamin A, or hyperthyroidism, or various medication. So treatment part, mild, moderate, asymptomatic, outpatient management, oral hydration, lot of fluids. And this is the one, in fact, there are two conditions. Even if there's a hypertension, we tell the patient to take a lot of salt. One is hypercalcemia due to hyperpara or other things. And second is a pheochromocytoma. Why? Because by giving sodium, it will be causing sodium excretion, which will lead to the calcium excretion also. And pheochromocytoma, by giving sodium, we are increasing intravascular volume. Then low calcium vitamin D diet, prevent immobilization, glucocorticoids if it is underlying granulomatous disorders, and check PTH levels and ultrasonography neck to rule out hyperpara and perform cancer screening. If severe, then we have to give isotonic salines, and after adequate saline hydration, after euvolumia, one can give fusimide in low doses. Then if patient is not responding, then hemodialysis with calcium-free dialysates, and bisphosphonate, zoledronic acid 4 milligram IV out 15 minutes. These days we are not using pamidronate. Earlier it was being used, and if later on, if required, surgical exploration. And just a mnemonic for the treatment of hypercalcemia: A, B, C, D. A is adequate saline hydration. B is bisphosphonates. We can give zoledronic acid. C is calcitonin, and D is 4: denosumab, dexamethasone, diuretics, and dialysis. So ABCD, adequate saline hydration, bisphosphonates, calcitonin, dexamethasone, denosumab, dialysis, and diuretics. That too, loop diuretics. So to summarize, in patient of hypercalcemia, check PTH to rule out whether this is PTH dependent or PTJ independent. PTJ independent, usually malignancy, endocrine causes, drugs and syndromes, detection of primary pathology and treat it, and treatment is correction of hypercalcemia. Thank you very much. I have finished. I'll be very glad to answer any queries and learn from all my learned delegates.
Thank you so much, sir, for the major deliberation. I'm sure our audience got to know so many things in this discussion. Sir, I can see a few questions from our
Yeah,
participant doctors. With all your permission, can I put them across?
yeah, please.
Okay. The first question is, how can we differentiate PTH dependent versus PTH independent hypercalcemia based on laboratory test?
Based on okay, fine. See, calcium levels are normal in both. Phosphate levels generally are low in both. Generally low in both, but it's more low in PTH related these things. And generally, magnesium levels are seen low in PTH related and not in PTH related. But differentiation point is at the level by doing the PTH levels. If PTH levels are suppressed, it is malignancy related. Malignancy related or PTH related other causes also. If PTH levels are normal, even if slightly lower than normal, but inappropriate for the calcium levels, these are due to hyperparathyroidism, PTH related causes.
Okay, moving to the next question. In which clinical scenarios should bone scans, PET scans, or genetic testing be considered for hypercalcemia?
Please repeat the question.
In which scenarios should bone scans, PET scans, or genetic testing be considered for hypercalcemia?
See, if hypercalcemia is due to, you are saying the bone scan. Generally, bone scan in most of the cases may not be required if it is primary hyperparathyroidism. But bone scan, basically, we look at that whether the involvement of the bone is due to the some mets or other things, then scan is required. Genetic causes, yes, genetic causes because there are so many causes of hyperparathyroidism which may be genetically associated causes of hyperpara, like in multiple endocrine neoplasia also it can cause hypercalcemia. Then certain malignant disorders can cause hypercalcemia. Their genetic testing may be helpful, and especially if it is the familiar hypocalciuric hypercalcemia genetic causes, or some Williams syndrome is occurring, and metaphyseal chondrodysplasia, in their genetic testing is required.
Okay, the next question is, how do we choose between IV hydration, biophosphonates, calcitonin, denosumab, and steroids in different hypercalcemia causes?
Yeah. See, whatever may be the cause of hypercalcemia, adequate IV's normal saline is the first therapy which should be given. Now, second mode of therapy is depending upon the underlying cause. But as I told you, generally causes there's an increased calcium coming from the bones. So, irrespective of the underlying cause, if there is no renal dysfunction, you can use after this little bit of this diuretics. You can use the this zoledronic acid. The zoledronic acid is a quite effective. It can be used, and if patient is not responding, well, then one can use the denosumab. But steroids are required if you suspect underlying granulomatous disorders or vitamin D related disorders. There you have to use the steroids. And steroids, in fact, sometimes in malignant disorders also help because osteolytic, local cytokine associated hypercalcemia will be taken care of the glucokine. But generally, I would say adequate saline hydration. After that, maybe low dose of diuretics, and this zoledronic acid should take care of the most of the cases. And some of the cases, recalcitrant hypercalcemia will require denosumab, and if not responding, then dialysis is the option.
Okay. We are taking the last question for today's session, that is, what are the red flags in hypercalcemia workup that should prompt urgent evaluation for malignancy?
Please repeat the question, ma'am. A lot of echo is there, ma'am.
Yeah. What
Please
are
repeat the
the red
question.
flags in hyper yeah. What are the red flags in hypercalcemia workup that should prompt urgent evaluation for malignancy?
Yeah, great question. See, Generally, if it is a you are sitting in the OPD at a symptomatic hypercalcemia cause, invariably it is the primary hyperparathyroidism. Red flag signs is the first time patient coming to you in a sort of a severe hypercalcemia, or patient coming in the ICU in a state of dehydration, or patient losing lot of weight, which is a malignancy sign of losing a lot of weight, polyuria is there. Then these are red flag signs. Generally, as I told you, in primary hyperparathyroidism, you will not find high calcium because calcium sensing receptor is still reactive to high calcium levels, and it is able to suppress PTH, but set point is at a higher level. Whereas in malignancy, this is autonomous. It is autonomous. It is not under the control of the calcium. So there is a rapid increase in calcium levels, and patient may come in the hypercalcemic crisis. And moreover, see, just to point out, hypercalcemia in malignancy denotes underlying severe malignancy. Generally, most of the patients may die within 30 days, which is not because of the hypercalcemia, because of the severity of the underlying disorders. And most of the malignancy related hypercalcemia, they die within 1 year.
Thank you so much, sir, for your expert opinion that you have shared. And I'd also like to thank all the participating doctors for your continuous participation at our platform. Thank you once again, sir, for your valuable time and for being with us at our platform and sharing such valuable insights.
Thank you
With
very
all
much.
your permission, can we end the live
Yeah,
here?
yeah, please.
Okay, sir. Thank you so much. Thank you so much, sir.